Hello, and welcome virtually to the Sonata patient events with Dr. Edwards and Dr. Dhanraj. My name is Teresa. I'm the monitor, and I am a nurse advocate and educator for Sonata. I feel like we're really lucky to have both physicians with us this evening to talk about Sonata and other options for you. So this event is meant to be interactive. You can put your questions in the chat and we'll address those questions at the end of the presentation. So Dr. Edwards and Dr. Dhanraj, tell us a little bit about yourself and then we could talk about fibroids.
Okay. Hi, I'm Dr. Kevin Edwards. I'm a practicing OBGYN physician with Premier Health in Dayton, Ohio. I've been practicing there for about 3 years. I've taken on doing the Sonata procedure over the last year and a half, and I've done several of those so far, and I'll be happy to speak with you guys about those today.
Well, good evening. I'm Dr. David Dhanraj. I am a practicing physician with Wright State Physicians, OBGYN. I'm also the chair of the Department of OBGYN for Wright State University's School of Medicine and Associate Dean for Clinical Affairs for the School of Medicine. Been doing this procedure, the Sonata procedure, for about the same amount of time as Dr. Edwards. Definitely excited about sharing this new option for a lot of our patients. I mean, it was really interesting to think about. Just a couple of years ago, I wish I had this option for some of the patients that we had to do something more invasive. So I'm very excited about talking about this with you tonight. Oh, you're muted.
I'm sorry. So let's talk a little bit about fibroids. Most fibroids are asymptomatic or without symptoms. For the women that do have symptoms, the symptoms are heavy menstrual bleeding, low pelvic pressure. You could have problems with urination, constipation.
I first started having symptoms about 7, 8 years ago.
In my early 20s.
Probably 8+ years ago.
4 years ago.
When I first started my cycle at age 14, and they were always horrible.
And some of the stories that women have communicated to me have been otherworldly. They really modify their whole lifestyle as a result of their symptoms.
My symptoms got so bad that I actually had to change careers because I could not continue taking days off of work because I couldn't get out of bed.
My symptoms were so bad to the point I will be in the house a week straight.
It was essentially having my period all month long.
When I was taking sick days because I just couldn't get out of bed, painkillers were not helping.
I don't remember a time when fibroids didn't affect me.
My doctors told me that the best treatment would be most likely a full hysterectomy to treat this.
They offered me birth control pills to help with the bleeding.
I went to several doctors looking for an alternate opinion, and I consistently got hysterectomy being my only option.
Hysterectomy or myomectomy, I believe, is the other option she gave me.
A hysterectomy was my only option.
The hysterectomy. And then they suggested I could take some birth control pills.
Minimally invasive hysterectomy, your recovery is 3 to 4 weeks. If it's done open, it's a 6 to 8 week recovery.
I thought a better option would just be to deal with the symptoms than to have my body parts removed.
There were not any treatments for it.
The Sonata treatment is for women with symptomatic fibroids who want to preserve their uterus and avoid major surgery.
After my Sonata treatment, I saw relief. I wasn't having constant periods every single day.
It just started getting lighter and lighter.
I say about a 75% reduction from what I was used to.
I do not suffer from the pain, the cramping, or the heavy bleeding like I did prior to the Sonata treatment.
I don't have to worry about going anywhere when I'm have my period. I don't have to worry about if it's going to be an incident like before.
The procedure takes less than an hour typically. Recovery is a half hour to 45 minutes before you're discharged and ready to go home.
I no longer have to carry an extra change of clothes. I don't have to keep anything on my mattress.
You have a chance to actually have this treatment and know that your life can be so much better.
Absolutely, hands down. Investigate it, check it out. I would look at it as a first option.
I know this sounds weird, but I can wear white pants and not be nervous about it.
I would definitely tell them to try the Sonata.
The Sonata treatment is very effective. 95% of the women have a reduction in menstrual flow after 1 year, and 97% would recommend it to a friend.
Look into the Sonata process.
Just give it a chance.
It's a game changer.
I never got to wear tampons before. I can wear tampons now.
I believe it's the way to go.
Okay.
Okay.
All right. So fibroids. Fibroids are abnormal growths of the smooth muscle layer of the uterus. There could be several types. Some of them are demonstrated here. It's one of the most common tumors that grow in the reproductive age of women, and several modalities to treat these. Next slide.
So as you saw in that previous diagram, they're not all the same. And the symptoms that you get with them, as well as what we can do with them, sort of depend on where they're at. When we say submucous, we mean kind of under the surface of the lining of the endometrial cavity, and pushing on that lining oftentimes affects periods, making them heavy, and can certainly have some effect on fertility. Intramural, those are in the wall, and they can also affect periods, and also just give you that feeling of pressure and bloating. And depending on where they're at, if they're on the front, they can actually push into the bladder and actually sort of affect urinary function. And then subserosal, which means kind of just below the surface of the outside of the uterus. That can, depending on the size, lead to some bloating and discomfort. And as you know, in the circle there, you know, especially the bleeding issue is where we get a lot of these problems that affect people's lives. Having heavy periods, canceling plans, worrying about you know, getting clothes soiled, being off work, all of those things oftentimes our patients associate with having fibroids. Go to the next slide.
So in the US, as you can see, about 70% of white women and maybe about 80% of Black women will have uterine fibroids before the age of 50. It is estimated that 20 to 50% of these women with fibroids may experience symptoms that can include, as Dr. Dhanraj mentioned, bloating, heavy cycles, pain. Some women have GI symptoms or urinary symptoms. And in each year in the US, more than 2 million women undergo treatment for these symptomatic fibroids. We also notice that fibroids may run in family, meaning if your mother or sister had fibroids, likely a chance that you may also develop fibroids. Next slide.
So, yeah, how do you know if your symptoms are caused by fibroids? It's the importance of doing your yearly checks with your OBGYN. And because that oftentimes we're able to detect these during a routine clinical exams of the pelvis. But you know, this is the stuff that we want to make sure we talk about, and we do a lot of asking questions about periods. You know, are the periods heavy? Are they prolonged? Are they affecting your life? You know, are you showing signs of anemia? Because really there's options to treat that. And the longer you go without treatment, that, you know, these symptoms can continue to worsen and the fibroids can actually continue to enlarge. And so if we do think that, you know, we have concerns about fibroids from our exam, we often will confirm them with an ultrasound. We'll sometimes map them out with more advanced diagnostics like an MRI. But that's typically how they're diagnosed. You can go to the next slide.
Yeah, we also see a delay in women coming in to seek treatment or assessment for these symptoms that they may have. A lot of times, you know, as the data shows, about 3.6 years, with 32% of women waiting for at least 5 years before they come in with these symptoms or to seek management of the fibroids. 79% of women say they don't want invasive surgery or long recovery times. And I've actually experienced this with some of my patients that I've followed for years before they actually want to do something, especially prior to Sonata and less invasive procedures being available. Most women, well, I won't say most, but some women also want to preserve their uterus, even if they're not planning on having any more children. And that's something I've also seen in my practice as well. Next slide.
Yes, what are the treatment options? Keep going there. Heavy periods due to fibroids. There are more options, and that's what we're here to talk about tonight. We'll go to the next slide, and I'll do this one too. Number one, we typically will try a lot of medical treatments. You know, a lot of the birth control that we use, like a Depo-Provera or birth control pills. There's some other medications on the market. Could get the bleeding under control or symptoms under control. And then we talked earlier about like location of these fibroids. And so the ones that are in the uterine cavity or just below the lining, oftentimes we can go in hysteroscopically, which means through the cervix in a surgical procedure, and with some instruments, we can go and remove the fibroid that direction, and that's a minimally invasive approach. The next for a very, you know, for fibroids that are causing a lot of heavy bleeding for sure. Cutting off the blood supply to the uterus is uterine artery embolization. So that's a procedure done by radiology. And oftentimes that can help reduce the amount of bleeding. That require, you know, as we go through these and go a little bit further, the recovery of these procedures is a little bit longer. The recovery after a hysteroscopic procedure is pretty quick. But this one, because we're cutting off the blood supply to the uterus, it gets causes a lot of pain as it's the blood supply is kind of reducing in the uterus. So that's what some of the issues that go along with that procedure. Laparoscopic or open myomectomies is when we go in either minimally invasive or with an incision on the abdomen, and we remove the fibroids from the uterus and then repair the uterus. These are often done for people that want to maintain their fertility. And then certainly hysterectomy is the ultimate option. That is more invasive and has the longer recovery associated with it, but it's definitive. We're removing the uterus, removing the fibroids along with that. So we can go to the next slide. I think I might have gone through a lot of this actually.
Yeah, you've touched on a lot of these.
Yeah, I'll just keep going here for a little bit to
Okay.
finish this slide out then. Yeah, so we talked about this. We're managing symptom with medical treatments, and oftentimes the stronger hormones, some that actually put you into a menopausal state temporarily, can cause the fibroids to shrink. Again, these are for people that don't want to have major surgery, but some of the side effects that go along with these treatments, such as menopausal symptoms and potentially osteoporosis, aren't great. And oftentimes we have to worry about fibroids recurring or regrowing after you stop the treatment. Okay. And actually, maybe we'll go every other on this one then, because
Okay.
this is pretty intense. All right, we'll go to the next one there, and Dr. Edwards can take this one.
Yeah, Dr. Dhanraj touched on the hysteroscopic approach. That is also incisionless. The uterus is preserved. Only the fibroid is treated. That may require may require more than one attempt to completely remove the fibroid. And also, we're talking about fibroids that aren't too let's say deep into the muscle layer of the uterus. So oftentimes if they're a little deeper, we can't get to it by this route. Often performed under general anesthesia. Patients may leave the same day sometimes, depending on how much needs to be done. We talked about limitation in what fibroids can be treated by that. And some studies show 15% of patients need a second procedure within 5 years.
Next slide there. And then we talked about this just quickly. We're basically cutting off the blood supply to the uterus in this procedure. And we're hoping that that will essentially cause the fibroids to die, but it doesn't, it doesn't exactly do that to the uterus, but it's when you cut off blood supply to any organ, that usually leads to a lot of pain, and that's why this recovery is a bit longer. Post-embolization syndrome kind of refers to that pain that people will get, and oftentimes people even need to stay overnight. The good thing is that it's through like the large veins in your groin, so it's not a big incision, but it is like kind of a needle, a large needle that goes into the groin and allows us to map out and get to the uterine artery. And again, there's risk of fibroids coming back. And that's a fairly high number of patients requiring additional treatment, which is usually a hysterectomy if this fails. Go to the next slide.
Right. And this was previously touched on as well. But the myomectomy that can be done by minimal invasive procedure. We use a few small instruments on the abdomen, tiny incisions, and to remove them may make a fairly larger incision to remove them, depending on the size of the fibroids. Or sometimes it may be what we call an open myomectomy, almost like a smaller cesarean incision or another type of incision to remove that and perform the surgery and to remove the fibroids. Again, the fibroids may come back. About 10 to 25% of patients may need additional treatment within 5 years, and then it may require inpatient stay overnight or a few days, depending on the incision that is used and how pain controlled is after that. And may, if it's an open myomectomy, it may require up to 6 weeks of recovery time.
And then finally, hysterectomy, which we mentioned, is sort of definitive, and it's actually, if not the most common, one of the most common surgeries performed nationally. A lot of patients undergo this to treat multiple types of things, but fibroids is one of the most common reasons why we do this. Hysterectomies can be done in several different ways. Incision on the abdomen, especially for larger fibroids. Sometimes we can't get them out any other way. Laparoscopically, they can be done, but then they need to be sort of, the fibroids in the uterus will come out the vagina, or in certain cases, we can do the entire procedure vaginally. And those laparoscopic and vaginal procedures have a quicker recovery than the abdominal, which is very much like a C-section in terms of the recovery. This ends childbearing, and we have studies that show that menopause occurs earlier in a lot of women who have a hysterectomy. Most of these procedures require general anesthesia, and the recovery we recommend for most of these is about 6 weeks, particularly important for those that undergo the abdominal route. That is a full 6 weeks of recovery. Next slide.
Okay.
So we
Alright.
will now talk about that. So you go ahead,
Yeah.
Dr. Edwards.
All right. So the Sonata treatment, you may hear of it being described as an incisionless procedure. It preserves the uterus, and it does not involve actually removing tissue or say physically removing the fibroid. It does not require general anesthesia, although all of my patients, I do use general anesthesia at the current moment. And it does not require an overnight stay in the hospital.
I think we'll hit play and we'll kind of walk you through an animation of this procedure. If it works there. There we go. So this procedure is done vaginally into the uterus. So again, no incisions. On the legs are some dispersive pads because this is using electricity, and that's how it's performed. And this probe has an ultrasound tip that allows us to map out the fibroids that we want to address. And the next it'll has a channel there where we'll deploy an array that goes directly into the fibroid, and we're again watching that directly with the ultrasound, and that goes in, and then we're able to once we can determine the safety, and that's what's really neat about this. This is so sophisticated that we can show that green area is the safety zones where we know that no tissue is going to be injured. But the red areas is where we're really wanting to address the energy or apply the energy to the fibroid, which will have the effect that we want. So all of this right now are all the safety checks and mapping out exactly where we want that array to be placed, as well as how much energy to deploy to keep just enough energy to hit the fibroid and preserve the rest of the surrounding tissue. And we can keep repositioning to treat additional fibroids as we go along. And the idea is that, again, we're not going to get instant relief after this procedure, but this radio frequency or this electricity that goes there will treat it, and then over time will cause these fibroids to shrink and reduce the symptoms. Again, what the advantage is that most of the women are ready to go back. They can go back to work. We're not cutting any incisions. This has very little, all my patients have had very little pain after the procedure. You can see as we go through a time lapse on this calendar, what we expect to see the fibroids do. Okay. Yeah, I guess package insert information there. But yeah, that's the basic procedure. We can talk more about that in the Q&A time if people have questions about that. Okay, next slide.
All right, this is basically performing these procedures in the US. I think they've been performing them a little longer in Europe. Some of the representatives can probably fill us in on that. But these more than 8,200 women have been treated worldwide. Plenty of articles on the Sonata procedure are available for patients that want some more information. There are handouts, and of course, speaking with your physician or getting referred to an OBGYN or physician trained in performing the procedure would probably be a first step if you're having any symptoms that you think could be related to fibroids.
So this is some of the most exciting, and certainly I think some of what led to myself and Dr. Edwards pursuing getting trained and being able to perform this for our patients. At least half our patients are ready to go back to normal activity the next day. But the exciting part is this 95% of the patients having a reduction in menstrual bleeding at the 12-month mark. And almost the same amount were satisfied after their 3 years of treatment. And, at the 3-year mark, pretty durable response and improved symptoms. So this is really what this is about, providing another option, but with good, and solid, high reliable results for our patients.
All right. So some of these, the what we call contraindications or reasons patients would not, we would not recommend this for patients. Obviously, if you're currently pregnant, any active pelvic infections, any known or suspected malignancy or pre-malignant disorders that are going on. We used to use these devices that goes into the tubes for women that wanted tubal ligation. So if you have a history of having those devices, we would screen that. That would be a contraindication of doing the procedure just because of the energy frequency that goes through and the risk of that being transmitted through those devices. If you currently have an IUD, then that would be a contraindication to this as well. All of these things would be screened by your provider and remedied prior to doing the procedure. It doesn't mean that it's absolutely we can't do it, just means we may have to do a few more steps prior to determining if you're a candidate for the procedure. Some other inserts over here. I don't think we need to go through all of those, but the procedure has been shown to be safe and effective, as Dr. Dhanraj has explained in the previous slides, and myself as well, and good results and good outcomes for patients as well. Some of the anticipated side effects or potential issues after the procedure, we discussed some cramping is possible. Some women may have a discharge for a few days. And then, worst case scenario, we'd be worried about any kind of fevers or infectious like presentation afterwards, which I haven't had any of those, but, of course, this isn't a procedure, so those are possible. There's also potential for you being allergic to any of the instruments that are used or the device that's used or any medications that you receive at the time. All of those things would be discussed and screened prior to or immediately after the procedure. Next slide.
And that's us. We are very much interested, and patients looking for this option. Certainly myself and Dr. Edwards are excited to talk to patients about this and provide this if it's the right patient. And so yeah, here's our contact information.
Perfect. Perfect. Thank you. Thank you both. I do have quite a few questions. If I can start with, do all fibroids require treatment?
No, all fibroids. Yeah, all fibroids do not require treatment. As a matter of fact, most women, or many women that have fibroids, if they don't become symptomatic and they don't get screened for like an incidental finding on like a CT scan or something like that, they go on without ever having symptoms. The fibroids that we do recommend treatment for would be those that come with those symptoms that we discussed, whether it's pain or heavy cycles, or, sometimes I'll have patients that come in and they come in for a urinary issue, but it's because there's a fibroid they're pressing on their bladder. So those women would require, or we would recommend, some kind of treatment for that. Usually it's the reproductive age that women typically have symptoms, or have, that's the time when fibroids are usually present. And as women get closer to menopause, sometimes those fibroids can shrink, especially if they haven't been causing any problems prior to that. But typically the women that come in or are having symptoms in the reproductive age we do an ultrasound, we find a fibroid, and we recommend management of that fibroid.
Thank you. I have another one for you. What causes fibroids?
Ooh, this is such a good question, and one that I wish we had better answers on. We know they come from one cell. Each fibroid comes from one cell that kind of reproduces. It's not cancer, but it's what they call monoclonal. There's been a lot of discussion, and a lot of what we worry about with disparities. A lot of our African American patients are getting more of these, numerous fibroids, and it seems to affect them more than other groups. And there's been discussion about like chemicals in the environment, beauty products. Nobody has a good answer yet of why they occur, what we can do to prevent them. So stay tuned. There's a lot of work being done in the research realm of trying to figure this out, but there isn't a solid answer for that yet.
Great. And how do I determine if I'm a candidate?
I think, so typically it would start with a patient, are you having symptoms? And we discussed some of those symptoms at length, in regards to like heavy cycles, painful cycles, some of those other issues that you may not think are related to fibroids, such as, constipation or, urinary incontinence or things like that. So if you think you have symptoms, I think that's the first place to start. Then you would want to either come in and see your OBGYN. We talked about yearly checkups, but you can make an appointment whenever you have symptoms, or whenever you think that there's something going on, you want to be checked out. And then you would come in, and then through the history taking, maybe additional labs, and maybe imaging, we can determine if you have fibroids through those modalities.
Perfect. Another question, does size of the fibroid matter?
It does. Absolutely. There's a certain number. I think the current understanding of this is as we get closer to 10 centimeters, and you think about what we're trying to do here, to be able to get enough energy to get enough coverage and the effect we want on that fibroid. It's very difficult as the fibroids are much larger. And so there's some things that we can do. Some of the medicines we talked about that we use to treat fibroids, we can use them to kind of get the fibroid into sort of a better zone of size that we can work with. But yeah, as they get larger, it's the treatment failure will go up. If so we have to make sure that it fits within the size criteria, but that's about what, I don't know, Dr. Edwards, is that what you currently understand about that size?
Yeah, typically around 10 centimeters or so is I don't know if I would try this procedure particularly with those bigger than that. But we talked about some of the medications to help shrinking them. But also this is where, we talked about the delay, 3 to 5 years. Sometimes women will have symptoms before they come in. And in that time period, fibroids can grow. So we do recommend yearly visits, or, if you're having issues with your cycles or anything like that, to see your GYN doctor so that we can catch those fibroids when they're smaller. Management options are more the smaller the fibroids are.
Thank you. Another question, how can I prevent fibroids?
If we could figure out why they form in the first place.
Yeah, there's not really
You can
anything
do
to
that. There's not
yeah.
good answers, but I think what Dr. Edwards brought up was a good point. Like the earlier we're able to kind of detect them and start addressing them, we've got more options for them. As they get larger and larger, we're limited, but in terms of preventing, there's not really been anything shown to prevent the formation of fibroids. And again, once we figure out the inciting factors that lead to these tumors starting to form in the uterine muscle, that would give us a lot of ideas of how to prevent it. But no, we're not quite there yet. But I hope you keep asking that as you go to your OBGYN. We should be on the literature and, figuring out, I think it'll be big news once we do kind of identify that, but I wish I had a good answer of how we prevent that.
Perfect, thank you. Another question, is a Sonata treatment painful, and can those fibroids that are treated grow back?
I think, so relative. It's generally not painful. The discomfort you would have is, typically some cramping, managed by a pain medication, is primarily what most women will experience. Like we said, most women go home the day off. You do get pain medications. Typically, my patients don't require those more than, less than a week if needed, if not for a couple days, maybe afterwards. So pain management is pretty, I would say, compared to some of the other surgeries I do, this would be pretty mild. In regards to coming back, and I think, we have some data on that, pretty much, symptoms, most patients within a year are symptom-free, decreased bleeding, and fibroids can grow back in other areas, usually not the ones that have been treated with the procedure. But can you have fibroids in other areas that maybe were too small at the time to be recognized, or grow in another area on their own? That's possible, but in regards to the fibroids that are treated, most likely not.
Okay, perfect. Another question, how long do I have to wait before my symptoms decrease after having the treatment?
So I think you saw some of the data that we look at. We get maximum, we know where we're at the year mark, but we would say, within about 3 months, we should start noticing significant improvement, and it should continue to improve over those next few months to get into that year mark. But that's when we've studied it. At the year mark is when we know but I think my patients have spoke of significant relief about between the 3 and 6 month mark. I don't know what your experience has been there, Dr. Edwards.
Same here. Yeah.
Great. There's a few questions related to pregnancy. Okay, so I'm just gonna kind of wrap it all up for you guys. Can you get pregnant after having the Sonata treatment? One wants to know effects on fertility, and again, reproduction after the treatment. Are you able to still reproduce after the treatment?
That's one of the advantages of this, is that it's uterine sparing, and there is more and more data being presented right now about fertility. They have cases of patients having successful pregnancies after treatment. And so that's one of the main reasons I think people pursue this, is they want to maintain that ability to have their childbearing preserved. And so we've that's what I would say, is that right now, they talk about, we're still working on having enough data to support that this is safe and that people, but it's ongoing. And that is one of the advantages I see for my patients, is that there's not been any, when we do other procedures like doing a myomectomy, and restoring if we were able to restore the uterus to normal size and normal contours, we think pregnancy outcomes are better. But anytime we make an incision on the uterus, there's risk of uterine rupture. This one doesn't have that, because we aren't making incisions on the uterine muscle wall. We're actually just treating the fibroid. And so some of that, that's one of the interesting things to think about. For me, doing a myomectomy, I have to do a C-section on all those patients if they get pregnant. And this one, we are not really obligated to do that for any other indication, unless she needs it for some other reason, but it's not because of this. So we think that fertility is something that is not impeded by this procedure.
Perfect.
I saw
Okay.
one of those questions about, do fibroids affect fertility? And that's a whole big discussion. And I feel like that's, I think people are able to get pregnant, but I've actually had multiple people over my career who I'm pretty certain that the fibroids led to a very high risk pregnancy, and there's been pregnancy losses at earlier gestations when they have lots of large fibroids that sort of impede the uterine cavity. And more recently, we had somebody, as I've been, working on labor and delivery, that we knew of, that she had a lot of fibroids and delivered extremely early. And so in that way, I don't think they directly, prevent pregnancy, but preventing a successful pregnancy, I think there's data for that.
Perfect. Any more questions? I think that's it. I just want to tell the ladies, if you'd like to schedule a consultation, a link is in the chat for both Dr. Edwards and Dr. Dhanraj. Dhanraj, my apologies.
Yep.
Or you can go on sonatatreatment.com, the website, and navigate that as well. I'd like to thank both of the physicians for their insight, their best practices and experiences. And I also want to thank the ladies for joining us this evening, learning about options and the Sonata treatment. And on behalf of Gynesonics, I want to say have a great evening to everybody. Thank you.
Thank you.
Thanks, everybody.